pleura. Those two pleura are separated by a mucus film. There's not really any air in between them. Due to injury, either a blood rupturing on the lung or penetrating trauma, such as a knife or a broken rib puncturing, you can have air that now goes between those two pleura. Okay? And that's, what does that air do?
Takes up breathing space.
Yeah, and compresses on the lung. So now you have a lung here that's able to expand when you take a deep breath in, but this lung can't. Now what's going on with the blood that's going to this lung? The blood that's going to this lung on the left is fine, right? It's getting oxygenated. But the blood that's going to this lung is not, right? So you actually wind up having what's called a ventilation-perfusion mismatch, right? So you're still getting blood flow here, but that blood that's leaving this lung is not oxygenated. So the patient's going to be in respiratory distress. They're going to have air hunger. So in a simple pneumothorax, you're going to have some respiratory distress or some shortness of breath, dyspnea. In a tension pneumothorax, there's so much air out here that it really, in effect, compresses against this, this lung. Doesn't let it expand. But how does it cause shock? And how does a tension pneumothorax, so much air in between the pleura, how does that cause shock in the descendant neck veins? Right? Because it's air around the lung. Why does that cause shock?
Cut down on perfusion.
What kind of perfusion? What's that blue thing right here? That in your body really is not blue, but Netter or whoever drew this is it's very nice and makes it blue. So right. So that's a big vein, right? That's the inferior vena cava, and the superior vena cava, which is right here, or which would be drawn right here, it courses down here. And when you have this huge amount of air that's compressing on the lung, it's not just compressing on the lung, it's compressing on the vena cava, right? So it's basically decreasing the blood return to the heart. And so you have basically an obstructive shock. So you have plenty of blood, you can have plenty of blood in your body, in your blood vessels, but that blood can't return to the heart, because it's basically being tourniqueted off. So that's why you get shock, and that's why you get distended neck veins, because remember, your external jugulars, right here, drain into that superior vena cava. So basically you're pinching off your vena cava, superior vena cava, that's why you get distended neck veins. You know, that'll decrease in breath sounds. It makes sense, right? Because you have all this air here. So when you listen to this side, you hear a nice normal breath sounds, but on this side, you hear decreased or absent breath sounds. And then hyperresonance if you're percussing. Cyanosis. By the time you have cyanosis in a tension pneumothorax, you're transporting the patient to the morgue. So it's a very late time. So a tension pneumothorax, the theory is that you should never make this diagnosis on X-ray, right? This always should be a clinical diagnosis. But that's in the academic world, and the real world is that sometimes we do see tension pneumos on X-ray and on CAT scan. You just do. It's just how things work, and if you're shooting an X-ray simultaneously with the resuscitation, it just sometimes you'll catch it. But yeah, in theory, if you see, and the thought is that if you see tracheal deviation and JVD, and you have absent breath sounds, and the patient's in shock, then before the X-ray is even done, you should needle their chest or put a chest tube in, or both. So an open pneumothorax, how is this different? So what's this? This is a wound in the chest wall, right? Say this guy got shot. Got shot here, he has a little injury to the lung. How is this different than a normal pneumothorax?
You have blood filling space?
So there's a hemothorax, good. There's a hemothorax, but we'll say this wound is a big wound. So it's that big shotgun wound that we saw before. Okay? So it's a sucking chest wound, right? The theory is that if this wound is the size of 2/3 of the trachea, then air will preferentially go in here, as opposed to in the mouth and down here. Okay? And really it just comes down to air, like humans, go the path of least resistance. Right? We do things the easy way. And so if this wound is big enough, and again, the theory being 2/3 of the size of the diameter of the trachea, now air is going to preferentially go in through here. It's going to suck in and turn into a tension pneumothorax. Okay. So how do we address this? Four-sided occluded bandage?
No.
Seal it off?
Leave one side.
Why?
So you can use it as like a
Escape
sweater.
valve.
Yeah, yeah.
Like,
Does everyone, that makes sense, right? You put a occlusive dressing, but leave one side open. This way, it can act as sort of a flutter valve. You can allow for egress of the air out, but then every time there's an attempt for air to go back in, it's blocked up by the dressing. So a three-sided cover with a defect. Place the chest tube distal from the wound. Don't put the chest tube through the wound. And then the patient will likely need a thoracotomy. Flail chest and pulmonary contusion. What's the definition of a flail chest? Why do we care? All right. So it's sort of an academic definition. It's 3 ribs with at least 2 fractures each. And why does that matter? Okay, rib fracture is a rib fracture, right? It's painful. You don't want it. It's painful. Has anyone here had a rib fracture before? Hurts, right?
Yeah.
It's like heck. Okay, so, but why is this different? So actually, that's a great point, which is that a flail chest is by itself not the biggest deal, okay? But it's representative of underlying pulmonary contusion and pulmonary injury. For something to require that much force to fracture your ribs in this kind of pattern, you know that the lung lying right behind it is severely contused, right? This just makes sense. But when this segment here, which they're attached to each other with some ligaments here, some muscles, ligaments here, when your chest wall, when you take a big deep breath in, your chest wall rises, but this flail segment theoretically will cave in. So it will move independently. But again, from our perspective, what's the big deal about this? It's usually representative of significant injury and hypoxia. And these patients need pain control and sometimes selective intubation. Is this the immediate life threat that we're going to need to treat in the field? No. Certainly good to know about, but massive hemothorax, that is. Okay, so the definition of a massive hemothorax, instead of air being around the lung, it's blood. Okay.
Do the flail chest sections cause this very often?
Does a flail chest cause a massive
Because of the
hemothorax?
contusion in the lung?
Great question. Usually not. Usually not. The massive hemothorax is usually more of a laceration to some of the larger pulmonary blood vessels. Can they be associated with hemothorax? Yeah, they can. And pneumothorax. We're talking about flail chest. But massive hemothoraces are usually a pretty big lung laceration. And the pure definition of a massive hemothorax is that when you put the chest tube in, now all of a sudden you have 1.5 liters of blood on your shoes. Okay. There is a secondary definition, which is 200 cc's of blood in chest tube drainage every hour for the next 2 to 4 hours. Okay, but the initial 1,500 cc's, when you see that, then this patient has to go to the OR. So, massive hemothorax, right? Same physics, the same pathophysiology. There's blood, instead of